Thank you very much. It's a privilege to be here with you in Dublin. I'm a huge fan of ILFA and I'm impressed year on year what is achieved, and that's due to the effort of a lot of people, but in particular to Nicola for her passion and her energy. And it's great to see her on the international stage representing the interests of Irish patients and families. So talking to Nicola about what I should cover today, and I think some of you may have heard me speak before, and my whole life is focused very much around quality of life for people living with pulmonary fibrosis and how we measure that, how we can create good questionnaires, and those metrics are important for service development in terms of getting commissioners to put money into services and also for clinical trials as well. So when I started out on this piece of research to develop an IPF-specific patient-reported outcome measure, I was very keen to look at using patient-centered methodology so that the end result was something that very much belonged to patients and belonged to the IPF community. So I'm going to talk a little bit about that as we come to the end. But I think before you get to the outcome and before you get to the health outcome, something that informs the process is communication. And one of the things that I do with healthcare professionals is talk about communication in the consultation. And I thought what might be really interesting is to look at that from the consultee perspective and what you can take to the consultation that will help you in your dialogue with your clinicians. Because you've got a lot to think about in terms of the condition that you're managing. But often it's when the communication breaks down and there's misunderstandings that can cause a lot of stress and anxiety. And it may be that you've got a lot of clinicians that you feel you've got strong relationships with. But for those of you perhaps at the early stages of the process, I'm hoping it might be helpful and a little bit of fun as well. So one of the things that we discuss a lot in the academic circle is what can we learn in the IPF world from the world of cancer, from the world of oncology, because a lot of research has been done. And in fact, the Brompton model of care was set up based on the Marsden oncological approach by Dame Margaret Turner Warwick, who sadly passed away earlier this year. And this is a communication model that's used a lot in the cancer world. And I put it up just to think about the points within that. And one of the key things that you bring to the consultation and to that communication process is an exchange of information. And what you say is important to inform the decisions about diagnosis and the decisions about management. And there's often an awful lot of uncertainty about diagnosis at the beginning. I was talking to Mr. McCarthy. We were talking about familial IPF and smoking-related fibrotic lung disease. And some of you are possibly in the grey area of not really knowing what your diagnosis is. And so to help your clinician, tell them as much as possible about your working history, the jobs and exposures that you may have had, because that can help that process and it gives you ownership. And if there's something that you think about and you think, is this relevant, the fact that you've thought about it probably means that it is, so say it anyway. Then making decisions based on that information and about your care should very much be a joint process, and there's a whole academic institution that's focused on the art of informed decision making and joint decision making. But really important that you feel part of the process of your care. It's your body and it's your health, and do ask the questions if you're uncertain about why you're on a particular pathway. It's apt that the oncology model talks about healing relationships, because fibrosis is often compared to an aberrant wound healing process, and ideally it's a wound that we could heal, but in terms of the fibrotic process, sadly it's something that we can't. We can slow down the progress with the antifibrotic drugs. But in terms of the emotional journey, I think it's important to think about how you heal emotionally. And it's often a grieving process that you have to go through when you're given the diagnosis of a life-limiting condition. And you're going to feel angry, and it's fine to feel angry. Who wouldn't? And then moving to sort of stages of accepting where you're at and what can be done about that. And so you need someone to help you with that process, and that might be through ILFA support groups, or it may be that you need to be asking your GP for psychological support or your secondary care clinician. And then it's our responsibility to enable you to self-manage, particularly in a country such as Ireland, where you're far-flung, a lot of people living in rural communities. And you can only do that if you're empowered to self-manage, and so that you know who to contact when things go awry, and that you've got the information and the accessibility. I know Colin's going to talk to me a little bit more about technological ways to do that. Uncertainty is a big part of fibrotic lung disease, but it's also a big part of life in the socio-economic climate that we live in. With the weather we've recently had, we all face uncertainty. And uncertainty is often associated with distress. And we all feel distressed at different times in life. And that is normal to feel that way. So just because you feel distressed about pulmonary fibrosis, it doesn't mean that there's something fundamentally wrong. It's a normal reaction to having a condition. But it's learning how to manage that uncertainty that you're going to have to come to terms with, so that it doesn't cause distress that can be problematic. And if you're struggling with that, then it's important to ask for help. So I'd like you to have a look at the elephant. And we all think that elephants have 4 legs, but sometimes things aren't always what they seem. And we bring that into the consultation as well. You will have preconceived ideas of what's going to happen within that. And sometimes as clinicians, we look at a patient and might sort of start to be form some judgmental attitudes, which are not necessarily helpful. And so it's very important for us to think about how, which consultation style we choose. But I think there's responsibility on both of us to think about how we manage difficult conversations. So sometimes from our perspective, we care, and caring comes with its own emotional burden. And sometimes we might look to you to take us where you want to go. So we often feel a bit tentative about talking about things like prognosis. We worry about how people are going to cope with bad news. And so sometimes it's important for us to get signals from you that you want to have that discussion about where things are going to go and what support is out there. And this is about working in partnership so that we can help each other for the best possible outcomes. How often have you been asked, how are you? And we say, fine. And it's that sort of pre-conscious regulated response that taps in. And it might be because we want people to think that we're fine. It might be that we think that really the person asking isn't that interested anyway, and so fine closes the conversation. And so this picture is a walking holiday. I dragged my son along. It was walking in the Swiss Alps, and I value that I've got the capacity to do that at the moment. And we had a long conversation about his new walking boots and the importance of breaking those in before the trip, and that if he got blisters or bad feet, he would have to manage it because we were walking day to day. And so, of course, he's a young man and took some of it on board. And I asked him how he was, and he said he was fine. But it turned out that I spent about €60 on blister care when we got down to the valley, and he was in absolute agony for a few days of that trip. But he was concealing his vulnerability and his embarrassment about not having listened to his mother, and we all know mothers are always right. So I think it's important for us to take that further and maybe ask, you're telling me that you're fine. Do you want to leave it at that? Or do you actually want to tell me how you really are? And as much as we might look at people who are hesitating or maybe omitting to tell us something, you could think about that from your side of the table as well. If you think your clinician is being a little bit hesitant, say, is there something that you're not telling me? Or is there something more that we need to discuss here? It is our responsibility to help you to find a way to say what you want to say. Some people are good at that, some people aren't. And so again, I think it's fine as a patient or as a relative to say there's something that we want to talk about, but we're not really sure where to begin, or we don't know how to put this into words. And just acknowledging that there's some difficulty there then gives the opportunity to unpack that. We all know about the importance of having rapport, and you're always going to have people that you're more comfortable with than others. And I think it's fine to ask that you need to see somebody else, because it just doesn't work. That's life. We always have people that we gel with and others that we don't gel with so much. And we've talked a little bit about shared decision making. And the other important thing is knowing that you're getting the right information. I think that's something that ILFA do very well, particularly in relation to signposting. And thinking about how you take that information on board and how you want to receive that. Some people prefer to have a conversation. Some people might prefer to have written information to follow up after consultation so that you can digest it, think about it and ask questions. Or it might be that you're very happy engaging with electronic medium. But important for you to know how you like to get your information so that it's meaningful to you and you can use it in the best way possible. So there are different consultation styles. There's different technology that we can use to help with the decision, but there are fundamental ways in which people communicate, and some of you will be aware of this. But everyone sort of has their default setting. So it might be that you're hearing a problem. It might be that you're, as Irene said, going with the flow, that you're very kinesthetic in your speech. It might be that you see the bigger picture, that you're very visual, or it might be that you smell a rat. And these are very subtle things, but, and I have to apologise because after this session, communication and conversation with your loved ones is just never going to be the same again. But picking up on these things can help you to understand what people are saying, and sometimes using that same language can help to put you on the same level of rapport. And so doctors are taught different consultation styles, and Roger Neighbour, whose work I like very much, talks about these aspects of my battery's running low here. I'm not sure whether that's going to affect the system. So we'll come back to connecting. But it might be that when you go into the consultation, you think that you need to come out with a summary. There needs to be a little bit of handing over. There needs to be some safety netting and a little bit of housekeeping. Okay, thank you. So thinking about summarising, from our perspective, we need to know why you've come to see us. It might be built around getting a lung function test result, but there might be a lot of other things that you need to discuss. We need to know what your concerns and expectations are, and some of that can only come through listening. And then there's the focus on the clinical bit that's important. So if you have particular reasons for attending, write them down, because that can be a really good aide-memoire, even on your tablet, but think about what you want to get out of that consultation. And particularly for us at the Brompton, we're a huge diagnostic centre, and we're in a position where most of our patients are reviewed on a 12-month basis, and we rely on a shared pathway of care. And I don't know what your situations will vary depending on your centre, but that time is precious. And you need to get the most out of that consultation so that you're going back with the information that you need. So then we need to hand over to be sure that you're happy with the management plan. But you need to know what the management plan is as well, so that you've got a clear understanding of when your follow-up is going to be and what you're expected to do and what your treatment options are. And it may be that that management is just about you going away and thinking about some options, which is fine, but you need to know when you're coming back and when you can explore those options, and the practical clinical care will kick in. Safety netting, very important from both sides. And again, it's that managing the uncertainty. If that's something that you're struggling with and it's having a detrimental effect, we need to manage it. If it's uncertainty that's causing you a little bit of distress, but you're coping with it, then as I say, that's a normal part of life. And you need to know what to do when things go wrong, whether that's in writing, whether it's in memory, but what's going to happen at the minute. You might feel very well, but what if you do have an exacerbation? Where do you go? What is the plan of action? What is the contact number? And then from our perspective, we have to think that we're in the right place to see the next patient. We may have had a stressful conversation, and it's our responsibility sometimes to step away and get our mind in the right place for the next patient. But for you, the housekeeping might be making sure you've got all the forms and the forms assigned that you need for your blood tests and your pulmonary function tests, so that there's not going to be any problems with your follow-up care. And it might be also processing information that you've taken on board, thinking, how am I going to deliver this to my family? What am I taking from this consultation back to my family? What do I want them to know? What conversations do we need to have that are going to help and support? So this is a bit of a busy slide. And the main things that I wanted to pull out of this is that, you know, communication is an active process. I've putting in a little bit of effort here, to hoping that we can communicate. I'm not just hoping that it will happen. And so again, when you go to see your clinician, the more you get out of it will probably be proportional to a lot of what you put in as well. So do be very, very much an active part of that process. And Kieran very nicely talked about unpicking the lung tissue and lying it flat so that it covers a tennis court. And so that's a really nice image to have. So if your clinician is telling you you've lost 10% of your lung function, what does that mean? Ask them to draw it. Look at the tennis court. You know, what does that mean in real terms, so that you can relate to the information. Think or hear how someone is talking to you, and you can tell that if someone's getting anxious. And if someone's getting anxious, push them to say, you know, are you telling me everything that I need to know? Are you worried that I'm not understanding? Are you worried that there is something you want to tell me that you don't think I can cope with? So hear those tones of anxiety that you'll all be familiar with. Again, how we present ourselves in terms of expression and movement. Sometimes when a clinician wants to close a conversation, they might get up and put the hand on the door, and we're often taught that that's the way to close a consultation. And it might be that just because it's a time factor. But if someone's doing that, they're not necessarily intentionally being rude, they're just trying to say your time's up. But it may be that you've got important issues to say. So bring that out into the open and say, I can see that my time is up, but there's something important that I want to discuss. How can I follow up on this? Can I have an interim telephone consultation? Can I talk to the specialist nurse? Should I see my GP? Rather than just going away frustrated, thinking that you were only able to talk about 50% of what you needed to. So this is the bit that I want you to practice at home, is thinking about how people communicate, whether it's on a hearing level, whether it's on a movement level, whether it's on a visual level. And eye movements give away an awful lot. And so if I'm asking a question, for example, you know, how did you manage this morning going up the stairs? It might be that someone is remembering going up the stairs and they're visualising that, in which case the eyes will go up to the top left corner, and I know that they're visualising that. It might be that they're hearing the sound of the stair lift or hearing the sound of the oxygen, in which case the eyes tend to stay level. Or it might be that someone's thinking, gosh, how was I going up the stairs? You know, how was that for me? And that can give you subtle clues about where to take the questioning. On the other side, we've got the constructed elements about how people might be constructing, and sometimes that's can occur when people are not entirely telling the truth. So go home with your loved ones and ask some questions that you've always wanted to know the answer to, but don't come back and blame me if you think you're picking up the wrong things. And again, it often depends if someone's right or left-handed. If they're ambidextrous, it all goes to pot. And again, it's not an exact science. It comes from the neuro-linguistic programming literature, but it's an interesting element to communication to be aware of. And so how do you attain your maximum quality of life? And this is Maslow's hierarchy of needs that I've used to use a long time ago, but I've gone back to because I think it's very relevant to society that we're living in. So if you absolutely want to have your best quality of life, it may be that your priority is not around an IPF-related issue at the minute. It may be, and thinking of the recent storm that we've had, that you're struggling at home, that you don't have any electricity, and how does that impact on your oxygen? It may be that you're living in a very isolated place. It may be that you're on the top floor of a block of flats, and you don't have an elevator that works. And so again, it's important to think about things that are going to make the IPF easier to manage, and that starts with the basics. It starts about knowing that you've got enough money, you're getting the right benefits if you need benefits, that you're able to access your pension. Because unless you've got those essential needs sorted out, the IPF is a secondary issue. And then Wi-Fi on the bottom has become just an absolutely essential component of life for most people. And I know when I don't have Wi-Fi, I feel bereft, which is why the walking holiday in Switzerland was good, because I couldn't answer emails for 48 hours. And after the initial feelings of anxiety, I actually quite enjoyed it for 24 hours. We have to embrace technology. There's a lot of information out there, but it's important to be discerning about how we access and use that information. And again, partly it's our responsibility to empower you if you have grown up and you're not part of a generation that is comfortable with technology. That said, from my research experience, I find that a lot of people over the age of 70 are more technologically literate than people in their 30s. If you're reading information and it seems simplistic and you want more, it's because the people who produce basic health information have to work on the fact that the average literacy age is 12. And that's just commonly accepted internationally. So it doesn't mean that anyone's trying to insult your intelligence. It means that that level of writing is what is needed for most of the population. So if you need something more than that, ask. And we now have lots of different ways in which we can embrace technology. And so we then can capture outcomes in different ways. So the idiopathic pulmonary fibrosis patient-reported outcome measure is now out to validation, and we're looking at using that in the IPF app as well, which Colin will talk a little bit about, to see how people like to record their information. And collecting the impact of pulmonary fibrosis, how it affects you from a breathlessness perspective, emotional perspective, and an energy level. It's important that you get feedback in a meaningful way as well, so that you can monitor your progress over time and identify areas that you're struggling. So it might be that breathlessness isn't really a problem, but the fatigue is hugely problematic. And collecting information in a systematic way can then help to plan appropriate interventions. And so, along with the collecting data in a questionnaire format, we've also been doing some work with handheld spirometry. And Kieran talked about the importance of pulmonary function testing. Spirometry at home is different. You're never going to get the same measurements on a home spirometer as you are in a laboratory, but that's okay. If you're doing spirometry at home, you're measuring like with like, and you are self-regulating, and so it is reliant on you and your effort and technique. But it does provide a way for you to self-manage, for you to share the information and the results, and we do think that it can help us to predict progression, and that might be important. It might be important in relation to predicting infection and thinking about whether we need to offer antibiotic treatment. And there's a lot of work that's ongoing, and again, Colin will pick up on this. So I talked about using patient-centered methodology. It's something that I feel quite passionate about, that it's something that one shouldn't just pay lip service to and to tick the box on the funding grant application. And so, as part of the this research, I had a patient group, patients and caregivers and multi-professionals, and we worked together in parallel. It was like a study steering group. And so, not only were patients participants in the study, they were part of the research team. And not only were healthcare professionals researchers, they also participated in the research process. And it was really interesting, and I'm just in the process of writing that up now. And I also wanted to show you that generated output. This is a tribute to Derek, who was a fantastic patient. I really miss working with him, and he sadly passed away earlier this year. But we worked together on the need for patient-centered clinical research in idiopathic pulmonary fibrosis. Derek didn't want to be listed in the paper because at that time he didn't want people to know about his condition because he was still working. And some of you might be in that position. So that doesn't mean to say you can't participate. You can do so anonymously if that's better for you at this stage in life. And we've also been to conferences together, and it's been a fantastic experience. I've learnt so much from my patients. I'm not going to labour this slide, only to say that there's often a perception that randomised controlled trials are the gold standard. But if you're doing different kinds of work, so you're looking more at qualitative work that's based around focus groups and getting information through conversations, there are different techniques that you can use. And if you do 3 of those methods, then you're triangulating it, and it's thought to be as reliable and as gold standard as an RCT. So it isn't second-rate research. It's very important, and there is no reason why elements of that can't be incorporated into clinical trials as well. So just to show that the IPF PROM covers the UK and Ireland, these are the regions that people contributed to a third round of the Delphi. And as you can see, Ireland has a good representation. I'm very grateful to everyone who helped with that process. And now we're looking at translating it. So it's currently in Brazil and Denmark and Holland. And I'm looking at other sites as well, and thinking about how we can have an international approach with using a standardized measure, so that you don't get into a situation where you're completing lots and lots of questionnaires that can make you feel quite low. And in fact, I had a conversation with one of my patients yesterday. Thankfully, she found this questionnaire okay, but some of the other longer ones she found focused very much on the negative aspects of health that she ordinarily wanted to forget about. So it's important for us as clinicians to think about questionnaire burden. And if you're finding it difficult to fill in questionnaires and it's making you feel low because the questions are negative, don't do them. Just say it's not the right time and it's not the right place. And that would go for me and my work as well, because we shouldn't be adding to your distress. That would lead very nicely into Colin's presentation, but I just thought I'd throw this in just to give you something visual and to lighten the mood as well. So this is a piece of work I did with Fina Cave, who is an amazing music therapist. We got a little bit of funding to do a rhythm and song for breath management in IPF. There's a lot of work that's done around singing for breathing in COPD, and we were interested to know if people with a restrictive lung condition needed a different approach. And our conclusion is that in fact they do. There are aspects of singing or using voice that is a little bit different, but once you've mastered some of those techniques, then from a therapeutic perspective, mixed singing groups are fine. And it's important to think about whether you're singing for fun or for pleasure, or whether you're singing as part of something that's constructed like a pulmonary rehabilitation program. So this is very much about the structured singing for lung health. So what I'm going to show you just a short bit of video, which is about 5 minutes. Am I okay on time? And I'm participating in this, and I've learned that I'm really discoordinated, but it's important that I'm as part of the process as well. So I shall just pop this on and you can see a little bit of what we did.
To go a little bit too fast, which is my fault. So we want to make sure that we keep this pulse going and we don't alternate it and make it into the offbeat. So the offbeat would be that. So just so that you know, let's have a play of this. Something I'd like you all to think about, we're going to do our physical warm-up in a minute. I want you to imagine that you've got a large balloon in your belly, in between the bottom of your rib cage and the top of your pubic bone. And that balloon is nice and inflated. So what that means is, and Effie's demonstrating beautifully, is that there's a big square. Keep clapping. There's a square here, which is nice and inflated with that balloon. So if we just let the balloon collapse now, what happens? It's a good look, Alan. So can we make sure that we try and keep our balloons in our middle of our bodies inflated at all times? Good. So now just the hands. Well done. Hang on, Alan, join us. Yay! So that's 1 and 2 and 3 and 4 and 5 and 6 and 7 and back to the legs. 1 and 2 and 3 and 4 and 5, 6, 7, 8. So there's an on-beat and an off-beat, and we're trying to keep with the on-beat. Getting technical already. Right, let's do it. I'll start with me and we'll go round to my left. Jambo, jambo, jambo sana jambo, jambo sana jambo. We'll do another one of those. Jambo, jambo, jambo sana jambo, jambo sana jambo. And I'll do 2 with my name. Jambo, jambo, jambo fini jambo, jambo fini jambo. Jambo, jambo, jambo fini jambo, jambo fini jambo. Thank you, Pepe, you were right, I was wrong. Effie. Jambo, 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 Effie jambo, jambo, Effie jambo. Really good pulse keeping. Jambo, 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 Effie jambo, jambo, Effie jambo. Jambo, 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 Alan jambo, jambo, Alan jambo. Jambo, 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 Alan jambo, jambo, Alan jambo. Jambo, 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 Dylan jambo. Jambo, 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 Paul jambo, jambo, Paul jambo. Jambo, 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 Paul jambo, jambo, Paul jambo. Jambo, 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 Pepe jambo, jambo, Pepe jambo. Jambo, 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 Pepe jambo, jambo, Pepe jambo. Jambo, 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 Peter jambo, jambo, Peter jambo. Jambo, 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 Peter jambo, jambo, Peter jambo. Jambo, 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 Henry jambo, jambo, Henry jambo. Jambo, 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 Henry jambo, jambo, Henry jambo. Sana. Jambo, 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 sana jambo, jambo, sana jambo. Jambo, 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 sana jambo.